Assalamu alaikum. Today we will discuss surviving sepsis campaign, guideline for treatment and management of septic shock and sepsis-associated organ dysfunction, pediatric guidelines, Feb 2020. The first few slides I will view in a bit. It talk about the recommendation of strengths and for the class 1 strong benefit proved to be more than risk. Suggested for us is in this recommendation, it is equal to I recommend or we recommend. So every I recommend or we recommend, it equal to strong evidence. For moderate benefit, more than risk, but less than in strong. The phases suggest it is reasonable, can be useful, it is beneficial. For weak recommendation, benefit equal to risk, yani benefit equal to no benefit. The phases it may be reasonable, might be considered. Usefulness, effectiveness is unknown, unclear, uncertain. Class 3 no benefit. هتبقى benefit يعني less than risk or equal to risk. The phases in presentation, it is recommended, it is not indicated, should not be performed. For the quality of evidence, the one with randomized controlled trial, it is high quality evidence. The one who non-randomized, it is moderate evidence or weak evidence. So we will start the one title, screening, diagnosis, and systematic management recommendation for management of septic shock. And the children who present as acutely unwell, we suggest implementing systematic screening for timely recognition of septic shock and other sepsis-associated organ dysfunction. Systematic screening need to be tailored to the type of patient, resources, and procedure within each institution. Evaluation for the effectiveness and sustainability of screening should be incorporated as part of this process. We are unable to issue recommendation about using blood lactate value to stratify children with suspected septic shock or other sepsis-associated organ dysfunction into low versus high risk of having septic shock or sepsis. However, in our practice, if lactate level can be rapidly obtained, we often measure blood lactate in children when evaluating for septic shock and other sepsis-associated organ dysfunction. It is insufficient evidence. We recommend implementing protocol and guideline for management of children with septic shock or sepsis-associated organ dysfunction. We recommend obtaining blood culture before initiating antimicrobial therapy in situations where this does not substantially delay antimicrobial administration. It is best practice statement. For the antimicrobial therapy recommendation in the children with septic shock, we recommend starting antimicrobial therapy as soon as possible within 1 hour of recognition of septic shock. It is a strong recommendation, very low quality of evidence. In the children with sepsis-associated organ dysfunction but without shock, we suggest starting antimicrobial therapy as soon as possible after appropriate evaluation within 3 hours of recognition. These 3 hours, we do test to differentiate between two sepsis or septic shock or suspected sepsis. It is weak recommendation with very low quality of evidence. We recommend empiric broad spectrum therapy with one or more antimicrobial to cover or likely pathogen. It is best practice statement. For instance, على سبيل المثال, if it is community acquired sepsis, we will start with ceftriaxone. If MICA is suspected in the patient, we should add vancomycin. If it is hospital-acquired sepsis or septic shock, we recommend to start to add carbapenem or higher generation of cephalosporin like cefepime. When the patient immunocompromised, we should start with anti-pseudomonas like ceftazidime, and also to add antifungal treatment if the patient is immunocompromised. Once the pathogen and sensitivity are available, we recommend narrowing empiric antimicrobial therapy coverage. If no pathogen is identified, we recommend narrowing or stopping empiric antimicrobial therapy according to clinical presentation, site of infection, host risk factor, and adequacy of clinical improvement in the discussion with infectious disease and antimicrobial expert advice. It is best practice statement. We recommend using antimicrobial dosing strategy that have been optimized based on published pharmacokinetic and pharmacodynamics. We recommend the daily assessment, clinical and laboratory assessment for the escalation of antimicrobial therapy. This assessment should include a review of ongoing indication for empiric antimicrobial therapy after the first 48 hours that is guided by microbiological result and response to clinical improvement or evidence of infection resolution. This recommendation applies to patients being treated with empiric, targeted, and combination therapy principle, and with consideration of specific drug properties. We recommend determining the duration of antimicrobial therapy according to the site of infection, microbial etiology, response to treatment, and the ability to achieve source control. It is also best practice statement. For source control recommendation, we recommend that emergent source control interventional be implemented as soon as possible after diagnosis of an infection amenable to source control procedure is made. Appropriate diagnostic test to identifying the site of infection and microbial etiology should be performed, and advice from a specialist team as infectious disease team. Surgery should be sought as appropriate in order to optimize intervention needed to achieve source control. We recommend the removal of intravascular access devices that are confirmed to be the source of sepsis or septic shock after other vascular access has been established, and depending on the pathogen and the risk benefit of the surgical procedure. For fluid therapy recommendation, in healthcare system with availability of intensive care, we suggest administering up to 40 to 60 ml per kg in bolus fluid, each of which 10 to 20 ml per kg per bolus over the first hour, titrated to clinical marker of cardiac output, and discontinued if sign of fluid overload develop for the initial resuscitation of children with septic shock or other sepsis-associated organ dysfunction. In healthcare system with no availability of intensive care and in absence of hypotension, we recommend against bolus fluid administration while starting maintenance fluid. In healthcare system with no availability of intensive care, if hypotension is present, we suggest administering up to 40 ml per kg in bolus fluid, 10 to 20 ml per kg per bolus over the first hour with titration to clinical marker of cardiac output, and discontinued if sign of fluid overload develop. Clinical marker of cardiac output may include heart rate, blood pressure, capillary fill time, level of consciousness, and urine output. In all settings, the need for fluid administration should be guided by frequent reassessment of clinical marker of cardiac output, serial blood lactate measurement, and advanced monitoring when available. Sign of fluid overload that should limit further fluid bolus therapy may include clinical sign of pulmonary edema or new or worsening hepatomegaly. We suggest using crystalloid other than albumin for the initial resuscitation of children with septic shock or other sepsis-associated organ function. Also, there is no difference in the outcome. This recommendation takes into consideration cost and other barriers of administering albumin compared with crystalloid. We suggest using balanced crystalloid other than normal saline for initial resuscitation of children with septic shock or other sepsis-associated organ dysfunction. It is a weak recommendation. We recommend against using starch in acute resuscitation of children with septic shock or other sepsis-associated organ dysfunction. It is a strong recommendation with moderate quality of evidence. We suggest against using gelatin in resuscitation of children with septic shock or other sepsis-associated organ dysfunction. It is a weak recommendation with low quality of evidence. For hemodynamic monitoring recommendation, we are unable to issue a recommendation about whether to target mean arterial pressure at 5th or 50th percentile for age in children with septic shock or other sepsis-associated organ dysfunction. However, in our practice, we target mean arterial pressure to be between 5th and 50th percentile or greater than 50th percentile for age. We suggest not using bedside clinical sign in isolation to categorize septic shock in children as warm or cold. It is a weak recommendation, very low quality of evidence. We suggest using advanced hemodynamic variable when available, in addition to bedside clinical variable to guide the resuscitation of children with septic shock or other sepsis-associated organ dysfunction. Advanced hemodynamic monitoring may include cardiac output, cardiac index, systemic vascular resistance, or central venous oxygen saturation. It is also a weak recommendation with low quality of evidence. We suggest using trends in blood lactate level in addition to clinical assessment to guide the resuscitation of children with septic shock and other sepsis-associated organ dysfunction. In children with an elevated blood lactate, repeat tests that reveal persistent elevation in blood lactate may indicate incomplete hemodynamic resuscitation and should prompt effort as needed to further promote hemodynamic stability. For vasoactive medication recommendation, we are unable to issue a recommendation for a specific first-line vasoactive infusion for children with septic shock. However, in our practice, we select either epinephrine or norepinephrine as first-line vasoactive infusion, guided by clinician preference, individual patient physiology, and the local system effect. Also, we are unable to issue recommendation about initiating vasoactive agent, so peripheral access in children with septic shock. However, in our practice, we often or sometimes administer a dilute concentration of initial vasoactive medication, so peripheral line if central venous access is not readily accessible. Children with septic shock who require high dose of catecholamine, no consensus was achieved on the optimal threshold for initiating vasopressin. Therefore, this decision should be made according to individual clinician preference. We are unable to issue recommendation about adding an inodilator in children with septic shock and cardiac dysfunction, despite other vasoactive agents. However, in our practice, We sometimes use inodilator in children with septic shock and evidence of persistent hypoperfusion and cardiac dysfunction despite other vasoactive agent. For mechanical ventilation recommendation, we are unable to issue recommendation about whether to intubate children with fluid refractory catecholamine-resistant septic shock. However, in our practice, we commonly intubate children with fluid refractory catecholamine-resistant septic shock without respiratory failure. We suggest not to use etomidate when intubating children with septic shock or other sepsis-associated organ dysfunction. We suggest a trial of non-invasive mechanical ventilation over invasive mechanical ventilation in children with sepsis-induced pediatric ERDS without a clear indication for intubation and who are responding to initial resuscitation. We suggest using high positive end expiratory pressure in children with sepsis-induced pediatric ERDS. The exact level of high beep has not been tested or determined in pediatric ERDS patient. Some randomized controlled trial and observational study in pediatric ERDS have used and advocated for use of ERDS network beep to FiO2 grade. So adverse hemodynamic effect of high beep may be more permanent in children with septic shock. We can suggest for or against the use of recruitment maneuver in the children with sepsis-induced pediatric ERDS and refractory hypoxemia. If a recruitment maneuver is considered, the use of stepwise incremental and decremental beep titration maneuver is preferred over sustained inflation technique that have not been optimized through direct testing in pediatric ERDS patient. In all pediatric ERDS patients must be carefully monitored for tolerance of the maneuver. We suggest a trial of prone positioning in children with sepsis and severe pediatric ERDS. Research trial in adults with ERDS and the children with pediatric ERDS have emphasized prone positioning for at least 12 hours per day as tolerated. We recommend against routine use of inhaled nitric oxide in all children with sepsis-induced pediatric ERDS. It is a strong recommendation with low quality of evidence. We suggest using inhaled nitric oxide as a rescue therapy in children with sepsis-induced pediatric ERDS and refractory hypoxemia after other oxygenation strategies have been optimized. We are unable to issue recommendation to use high-frequency oscillatory ventilation versus conventional ventilation in children with sepsis-induced ERDS. However, in our practice, there is no preference to use or not to use high-frequency oscillatory ventilation in patients with severe pediatric ERDS with refractory hypoxemia. We suggest using neuromuscular blockade in children with sepsis and severe pediatric ERDS. The exact duration of neuromuscular blockade to use in severe pediatric ERDS patient has not been determined to date. Most of adult randomized controlled trial data and pediatric observational data support the treatment for 24 to 48 hours after ERDS onset. It is weak recommendation with very low quality of evidence. For corticosteroid recommendation, we suggest against using IV hydrocortisone to treat children with septic shock if fluid resuscitation and vasopressor therapy are able to restore hemodynamic stability. We suggest that either IV hydrocortisone or no hydrocortisone may be used if adequate fluid resuscitation and vasopressor therapy are not able to restore hemodynamic stability. For endocrine and metabolic recommendation, we recommend against insulin therapy to maintain blood glucose target at or below 140 milligram per deciliter, 7.8 millimole per liter. We are unable to issue recommendation regarding what blood glucose range to target for children with septic shock. However, in our practice, there was consensus to target blood glucose level below 180 milligram per deciliter, but there was not consensus about the lower limit for the target range. We are unable to issue recommendation as whether to target normal blood calcium level in children with septic shock or sepsis-associated organ dysfunction, but in our practice, we often target normal calcium level for children with septic shock requiring vasoactive infusion support. We suggest against routine use of levothyroxine in children with septic shock and other sepsis-associated organ dysfunction in sick euthyroid state. We suggest either antibiotic therapy or permissive approach to fever in children with septic shock or other sepsis-associated organ dysfunction. For nutrition recommendation, we are unable to issue recommendation regarding early hypocaloric or trophic enteral feeding, followed by slow increase to full enteral feeding versus early enteral feeding in children with septic shock or sepsis-associated organ dysfunction without contraindication to enteral feeding. However, in our practice, there is preference to commence early enteral nutrition within 48 hours of admission in children with septic shock or other sepsis-associated organ dysfunction who have no contraindication to enteral nutrition, and to increase enteral nutrition in a stepwise fashion until nutritional goals are met. Enteral feeding is not contraindicated in children with septic shock after adequate hemodynamic resuscitation who no longer require escalating doses of vasoactive agent or in whom weaning of vasoactive agent has started. We suggest enteral nutrition as a preferred method of feeding, and that parental nutrition may be withheld in the first 7 days of PICU admission in children with septic shock or other sepsis-associated organ dysfunction. We suggest against supplemental with specialized lipid emulsion in children with septic shock or other sepsis-associated organ dysfunction. We suggest against routine measurement of gastric residual volume in children with septic shock or other sepsis-associated organ dysfunction. We suggest administering enteral feed through gastric tube other than post-pyloric feeding tube to children with septic shock or other sepsis-associated organ dysfunction who have no contraindication to enteral feeding. We suggest against the routine use of prokinetic agent for treatment of feeding intolerance in children with septic shock or other sepsis-associated organ dysfunction. We suggest against use of selenium. We suggest against use of arginine, glutamine, and zinc for treatment of children with septic shock or other sepsis-associated organ dysfunction. We suggest against the use of ascorbic acid, vitamin C in treatment of children with septic shock or other sepsis-associated organ dysfunction. We suggest against the use of thiamine to treat children with sepsis-associated organ dysfunction. We suggest against the acute repletion of vitamin D deficiency for treatment of septic shock or other sepsis-associated organ dysfunction. Blood product recommendation. We suggest against transfusion of packed RBCs if blood hemoglobin concentration is greater than or equal to 7 grams per deciliter in hemodynamically stabilized children with septic shock or other sepsis-associated organ dysfunction. According to 2018 Transfusion and Anemia Expertise Initiative, TAXI, guideline for purpose of RBC's transfusion, hemodynamically stabilized, is defined as mean airway pressure higher than 2 standard deviation below normal for age and no increase in vasoactive medication for at least 2 hours. We can't make a recommendation regarding hemoglobin transfusion threshold for critically ill children with unstable septic shock. We suggest against prophylactic platelet transfusion based solely on platelet level in non-bleeding children with septic shock or other sepsis-associated organ dysfunction and thrombocytopenia. We suggest against prophylactic plasma transfusion in non-bleeding children with septic shock or other sepsis-associated organ dysfunction and coagulation abnormality. Prophylactic plasma transfusion refer to situation in which there is an abnormality in laboratory coagulation testing but no active bleeding. Plasma exchange, renal replacement, and extracorporeal support recommendation. We suggest using plasma exchange in children with septic shock or other sepsis-associated organ dysfunction without thrombocytopenia associated multiple organ failure. We can suggest for or against the use of platelet plasma. We can suggest for or against the use of plasma exchange in children with septic shock or other sepsis-associated organ dysfunction with thrombocytopenia associated multiple organ failure. We suggest using renal replacement therapy.
Khalid, how many slides are still remaining with you, please?
Only 2 or 3 slides.
Okay, تفضل.
We suggest using renal replacement therapy to prevent or treat fluid overload in children with septic shock or other sepsis-associated organ dysfunction who are unresponsive to fluid restriction and diuretic therapy. We suggest against high volume hemofiltration over standard hemofiltration in children with septic shock or other sepsis-associated organ dysfunction who are treated with renal replacement therapy. We suggest using veno-venous ECMO in children with sepsis-induced pediatric ERDS and refractory hypoxemia. We suggest using veno-arterial ECMO as rescue therapy in children with septic shock only if refractory to all other treatment. Immunoglobulin and prophylaxis recommendation. We suggest against routine use of IV immunoglobulin in children with septic shock or other sepsis-associated organ dysfunction. We suggest against routine use of stress ulcer prophylaxis in critically ill children with septic shock or other sepsis-associated organ dysfunction, except for high-risk patients like obese patient post-surgery. We suggest against routine deep venous thrombosis prophylaxis in critically ill children with septic shock or other sepsis-associated organ dysfunction, but potential benefit may outweigh risk and cost in a specific population. Thank you.